Good morning. I'd like to go ahead and do a voiceover on the postpartum depression pieces for mood and affect that we missed in our didactic lecture so that you're prepared for the exam in a couple weeks. Depression, so let me share my screen. Okay, postpartum depression. I've got a couple of things scattered throughout this presentation for you to look at and consider. But postpartum depression is in women who just had a baby postpartum immediately after birth. Um, it's a mental health condition, it's a disorder. There's actually 3 problems considered in postpartum psychological complications. We're only doing 2 of them in this semester because they hit postpartum psychosis or postpartum depression with psychotic features. So in this case, postpartum psychological are postpartum depression and the baby blues, which come before that or are not, they're completely separate, but they're earlier in the postpartum period the woman experiences them. So the postpartum issues that we're talking about, they're mental health disorders, but because this is a new family, they just brought a baby, happy time, and this mental health condition that the mom is experiencing can interfere with bonding relationship, can affect the whole family. Everybody's expecting happiness and joy. And when depression hits in the middle of that, it can be, if mom is profoundly depressed, it can interfere with the bonding time that mom may need at that early period. That's a really crucial time in bonding. It's also an issue if mom has tendencies for suicide, then that can interfere with her. And sometimes moms decide that if they're going to take baby with them. And so it can affect the safety and well-being of the mom or her other children. So right after birth, you have to think of what happens. They're particularly vulnerable to psychological, the hormone fluctuations, the change in roles and expectations, the increase in the I said roles and expectations, the added responsibilities of a newborn and the lack of sleep, and sometimes the lack of you just don't know. There's often a period of distress during that time and real disruption in the family life, the sequence and the way distribution of time and energy in the family is disrupted by this new critter that's come into their family. So any pre-existing problems that mom has had are more likely to recur in these first few weeks after pregnancy. And again, it can interfere with bonding, affect the child's emotional and social development. So with early bonding problems, we know show up later in life as other. So again, because we think it's happy and the mom comes in, everybody in the family is confused. Why is mom sad? Why is everybody depressed? Why is everybody talking badly about this? And so it can bother people around them, and it can actually drive her support system away, right when they need the most, criticizing them and they're concerned but not helpfully concerned. And so they can withdraw because they don't know what to say. So all cultures have experienced postpartum depression. It's well documented in all cultural groups around our world. However, manifestations vary from culture to culture. The support system varies from culture to culture. How people express emotion changes based on your cultural values, beliefs, and how you're brought up to believe that this is how I express this emotion. We know the time period for postpartum depression, that depression can last for up to a year after birth. Most of the time it's 6 months to a year, but it can last up to a year. If it lasts longer than that, it's postpartum depression. It's depression that we consider major depressive disorder and other depression concerns that we talked about last week. Postpartum depression by nature has to be self-limiting to that year postpartum period. What causes it? We are not positive, but again, we believe biologic and psychological and environmental or situational concerns. Sometimes it's multifactorial. There's other things involved in life in mom's well-being. We know that we have a massive increase in estrogen and progesterone during pregnancy, and birth those levels just plummet. And that hormonal change, we believe, is linked to this because obviously it only happens in that postpartum period. So that's the single biggest biologic change that's going on. We know that, again, the biggest risk for postpartum depression are people with a history of depression or a previous episode of major depressive disorder. And then when these hormone fluctuations and life changes occur, these pre-disorders are likely to rear their ugly heads. We also know that there's other risk factors. On your original slides that you have, there's a list of risk factors. I'm that with a list of risk factors presented later in the slideshow. So we'll come back to these after we've done the background stuff here and we're into assessment of risk. So we know that any woman facing major difficulties with interpersonal issues, logical problems, are at risk for depressive disorders. We know that pregnancy and birth increases this risk, complications of pregnancy and birth, long labors, problems with children who have congenital or genetic disorders are increased risk, the health of the baby during pregnancy and immediately postpartum increase the risk if anything goes wrong during that time period. Any baby term with birth weight or with problems, illness, and other problems increases mom's risk. If mom is in a relationship where there's partner violence happening in the family, then they're obviously at risk for increased postpartum depression. I shouldn't say obviously. We shouldn't. If they're involved in a violent relationship, then they are at increased risk. And again, we talked about cultural practices can impact postpartum depression, and it can be positive or negative. In some cultures, all the burden of baby care goes to mom, and mom has a different value. Mom has to be isolated for a period of time from other people, and all those kinds of things can interfere with the relationships, with the flow. And postpartum depression is a condition that primarily affects mom. There are conditions for dad. Dad doesn't have hormonal change, but dad has role change. He has social change. He has changes in responsibilities and expectations. And the baby pregnancy can be wanted, unwanted. All those kinds of things can interfere with dad too. But we don't call dad's postpartum depression a whole different sequela that affects the man. You do want to be aware of it and you want to educate about him unit. Mom and dad emotional changes should be addressed in the postpartum period before the family goes home. We'll talk about that. So what can nurses do about postpartum depression? Well, we can offer anticipatory guidance. We know, hey, mom, baby blues are pretty common in some women. If it's coming, it might be coming for you. These are the symptoms. If you have these symptoms, please seek help. It can affect you in your baby. Help urgently and immediately. It is not a bad thing on you. It's a health concern that can happen based on hormones and neurotransmitter disorders. So we also want to assess the mental health of new moms in the postpartum unit. We want to take a basic baseline assessment on how they're doing. What's their overall mental health status? Have they had preconditions, and has it come up during pregnancy? Have they been battling with something? If necessary, we want to make referrals early and immediately. And if you ask and make those referrals, because referrals can always be stopped, but you can't get them back if you needed to make them and you didn't. Pretty rare that moms actually kill themselves and their babies, but it can happen. And so it's now a standard of care that we teach in postpartum girls early when we see that. Mom will get asked about this in the postpartum unit at the hospital. They'll get asked about it on their first postnatal visit, but not all moms come to the hospital. Some moms do home births. Some moms have birthing coaches at home that care for them, doulas, other kinds of cultural considerations. So we as nurses may not immediate postpartum period, and they may or may not seek postpartum care as we expect in the Western society. Be watching in the environment for these moms as they come into your scope of practice in whatever setting you're in. 70% of moms experience the baby blues. That's, again, the hormone fluctuation that is a normal self and doesn't really interfere with mom's care for herself or the baby. But if they get the depression can be severe enough to incapacitate the mother from caring for the baby. The baby blues are just mild depression, just kind of down, you're crying. So the postpartum depression is that intense, pervasive sadness with labile mood swings. And we talk about as things that happen during depression. Again, the hormones and the amino acids in mom's body can plummet up to 200 times within the first 24 hours. Start within the first 10 days. If mom can get past 10 to 14 days and they're not having sadness and crying and weepiness and mild depression, then they've made it past the baby blues period. Baby blues is self-limiting, lasts up to 2 weeks, just tearfulness and a little bit of discomfort. But mom is still well able to take care of baby. Postpartum blues, again, resolve. Postpartum depression generally requires intervention of some sort, and it can last up to a year after the birth. Multiple births, preterm births, we already talked about preterm births were higher risk with sick babies. Multiple births also can be at increased risk. Think about the abilities and the time and the hormone changes on mom. So again, baby blues is not postpartum depression. Mom just has mood swings, sadness, anxiety, often can't get to sleep, and may have a little transient loss of appetite, resolves in a few days. Postpartum depression, severe, intensive sadness, severe sadness, labile moods. Labile means it's bouncing all over the place. Oh, I'm so happy with my baby. Oh, horrible, this pregnancy's changing my life. Like, I'll never be the same. Everything's hopeless. I can't take care of the baby. So, and labile goes back and forth. You know how that's going to be. And this overwhelming, unending sadness that mom can't kick. We do treat this with medication, therapy, and electroconvulsive therapy. Remember, ECT and antidepressants and anxiolytics were commonly used for major depressive disorder. There's some other interventions, sometimes antipsychotics and things. We don't have to give antipsychotics or postpartum depression generally because they're not having psychotic features. Postpartum depression without psychotic features. And so typically it's antidepressants, anxiolytics, and ECT can be used just like disorder. It can lift mood, series of 3 treatments. Generally, it helps tremendously, but it also causes that temporary loss of mom is at risk for seizures during the ECT. So we have to be cautious with that and be aware that they might need a component during that ECT. So psychotherapy is when they come in to see a psychologist, and they'll focus on mom's roles, and then monitoring and being aware of suicidal or homicidal tendencies. If they have those thoughts, then they're going to get more immediate intervention. If somebody has suicidal and homicidal concerns, we're going to intervene. We're going to talk about suicide in a little bit. So postpartum depression with psychotic features is called postpartum psychosis. We'll talk about it at length. And mom doesn't just have depression, she also has delusions. She believes the baby may be possessed or at risk. Maybe they have overwhelming thoughts of harming themselves or their baby. And so they have these false beliefs and sometimes hallucinations. And it is an emergency or line of sight at the home. And it requires antipsychotics and mood stabilizers. But that's, we're not testing this semester, but when you do the reading The reading's got all three disorders, blues, depression, and psychosis, jumbled up together. So again, just want to, this exam is baby blues and postpartum depression are the only things you want to be concerned about. Postpartum psychosis is a different situation and will be tested for. So who's at risk for postpartum depression? We've addressed some of these already. Somebody who had anxiety or depression before the baby was in a history or a history of major depressive disorder. Anybody who had a history of postpartum depression with a previous pregnancy. Someone with life stress over this last year. Somebody who doesn't have social support system in place. They may be alone with that baby. They may be unmarried. They don't have help during this postpartum period or someone to talk to. If someone who has marital relationship problems, and we talked about abusive, but other relationship problems, the family's on the verge of divorce, other kinds of problems within the home that can cause mom distress, can just add to. A woman who's had a history of premenstrual dysphoria, the premenstrual depression, they are higher at risk for that they're prone to depression with hormone fluctuations. We know this, and so they're higher at risk. Again, complicated pregnancies, preterm, a woman who's had the postpartum blues that doesn't go away can progress to postpartum depression. It is not always the case, and it is certainly a risk factor. Most of the time, it's not the case, but it is a risk factor. A woman who's experiencing low monetary stress is a factor in the family. Someone who has an unintended pregnancy where it wasn't planned or considered, a mom with low education, or a mom who's using substances for life coping skills in general. We've talked about in the postpartum unit, we screen mom's mental health, and we do a lot of teaching about baby blues, baby depression, and the risk factors and concerns of psychosis. We'll do community referrals or home referrals if we need to. We'll see patients in the home. They don't have to get inpatient with postpartum depression. We can see them and let them stay at home with their baby, with their family. We only usually admit with postpartum has become suicidal. And then we also will give psychotropic meds, the antidepressants, anxiolytics, and we'll use other treatments like electroconvulsive therapy. So what's mom look like? Hopelessness, sadness, worthlessness, helplessness, appetite change, sweets with not a lot of other appetite. Depression, sometimes women either don't eat, depression patients in general don't eat, sleepiness, sluggishness, and fatigue. They're tired, but remember, baby's not sleeping, so it's hard to separate who's tired. That's not unusual. So how does that run up a red flag? Well, if mom's not interested in her baby, doesn't want to care for her baby, mom who's crying, mom who can't concentrate, who seems to be confused and have trouble problem solving and priority setting, mom who has a fear of harming herself, who is sleeping all the time or not sleeping at all. So it's, again, the pervasive, intense sadness with labile, much more serious than the baby blues. It takes treatment. Baby blues resolve without treatment. Postpartum depression, treatment. So we're going to need to get psychotherapy, mood elevators like tricyclic antidepressants or anxiolytics. Most moms don't come in until they feel like they're at a crisis point. They're not going to come in when it's like sad for a prolonged period of time. So the screening on that first postnatal, the first and second postnatal visits are really important because at a couple weeks, seeing that mom and that baby, that's when this is likely to be hitting. Excuse me. Again, the major mood disorders, it looks a lot like it. So it's not depressing. It's not much different from major depressive disorder, except the baby fears about being a good parent are overwhelming the themes. And in postpartum depression, might have binge eating, they might have sweet craving, and they probably have excessive sleeping. sleep. So the PowerPoint makes the point that assessment of failing to fall asleep or wakefulness in the middle of the night, you get up and feel get back to sleep, are real good risk factor assessments for PPD. So irritability is an overwhelming feature. That kind of not happy, irritability, snapping, they just don't, they can flare little things, ends up sobbing and despondent and sad and irritable with family for somebody would say, well, no real reason, very little, something. And so they'll also say, the baby cries all the time, the baby never sleeps, my husband never helps me, he loves me. I feel like hitting somebody. I feel like hitting the baby when she's crying. I feel like lashing out because I can't stop it. So those that are big red flags for us. And again, mom might be having panic attacks. All right, and so just this is one of those flow sheet infographics that would give you major information about postpartum blues, depression, or psychosis. Again, this content in level 3 is only blues and depression. But it's because the reading's so threaded together, it's nice to throw it in here so you can differentiate it. The key is, can you differentiate? This mom is depression, not psychosis. Treatment of psychosis comes later. And then, so what are we going to do? Antidepressants, anxiolytics, and electric ECT. We talked about that. We're going to do talking to mom about her concerns, her fears, her roles, her responsibilities for homicidal or suicidal tendency. Gradually, mom is going to get better over time, but most of the time, just not enough to help mom be a good, healthy mom, to help with the bonding, to restore mom's health. We really need treatment for depressive disorder. Most of the time, pharmacologic intervention or ECT. Moms sometimes take herbals, aromatherapy, massage therapy. They help. We don't have any solid evidence-based practice to say this is a cure. So you want to, and especially if they're breastfeeding, taking supplements or herbs can be an issue. So we want support groups for mom, because sometimes that other people out there experiencing the same thing that you can talk to and you can bounce ideas off of. If they're having dysfunctional relationships, then marital. And if mom is suicidal or homicidal, we might need to hospitalize. So again, care happens in multiple places to start. In the community settings, doctor's office and baby clinics. So pediatrician's going to monitor it, the obstetrician, postpartum follow-ups. Referrals might need to be made to community health settings, to psychotherapists. A lot of times obstetricians will follow up themselves with treatment because they are trained. Sometimes it takes more specific mental health practitioners that will follow up depending on mom's severity. Then providing, if necessary, hospitalization. So on the postpartum unit, observe the mother and the baby and their interaction. Are we seeing bonding? Are we seeing mom take responsibility for the care? We want to ask mom about the symptoms and make sure she can come back to us so they will understand, and we give them written materials to take home as well. We educate dad and mom so that both are aware if they're present. Mom's support system, whoever that might be. It also might be a mom or a friend that she's with. Everybody needs to be aware. If we need a health consult before they leave the hospital, we should request it if we see something that would give us pause. And then if we see psychosis at any point, we're going to give extra assessment, extra intervention, extra referrals. And we want, in the community, start lines on those follow-up visits. Nurses really need to actively listen, to pay attention to the words mom's saying. Follow up with questions if they say anything, and get the conversation going. Now that you had the baby, how are things going for you? Have you changed a lot since the baby's been born? I'm crying. Those kinds of questions can open the door, letting mom know it's safe and you're expecting to talk about these things. Mental health practitioners you refer to will be laid out by the healthcare providers or the agency you work for, of course. But if patient hospitalization, the provider and the family will make that decision. It's going to be only done with mom's safety or infant's. And again, if you are suspecting delusional thoughts, or suicide, have you thought about hurting yourself? Have you thought about hurting the baby? Then have you thought about a plan, or do you have a method that's in your mind? Ask the questions. It's really uncomfortable to ask those questions, but it's really to ask those questions. And then suicidal thoughts are most serious symptoms of PPD, but you have to intervene. If a woman is breastfeeding, point I want to make is if mom is breastfeeding, any medications she's taking is probably going to. If mom signs a consent to take medication and they're breastfeeding, they're signing the consent for the administration of that medication to themselves. And most medications have not been tested on infants. And so breastfeeding moms, we don't like to do a lot of prescriptions for, right? Is not breastfeeding, as the slide says, we can give SSRIs, tricyclic antidepressants, the serotonin norepinephrine and the MAOIs, mood stabilizers, all of them are on the board if mom is not breastfeeding. If mom is breastfeeding, there has to be much more specific in the planned interventions. So again, a YouTube video, I think that's the same at the beginning. All right, stop the recording.